Good evening, everyone. On behalf of President ASAMI India, I am Dr. Manish Prasad, and we are here witnessing yet another edition of the Curtain Raiser webinar towards the show of ASAMICON 2022, which is being organized at Pune in the Grand Sheraton Hotel on the 17th, 18th, and 19th of June 2022. Today, we have one of the most learned speakers of this generation. Sir is Professor Leonid Solomin from Russia. And today he will be talking on mid and hindfoot deformity analysis, planning and correction with the help of orthopedic hexapod fixators. Dr. Leonid Solomin does not really need an introduction. He is a master of masters, teacher of teachers, and an excellent orator. So all those who are attending on various portals, including this Zoom, YouTube, and other portals, I request you to kindly pay attention, and it will be a great session of learning. That much I can assure you. So over to you, Professor Solomin, my regards to you, and let us begin the proceedings. Thank you.
Thank you, my dear friends. Thank you. It's my great honor, pleasure to be invited to your education event, your education programs. Unfortunately, I didn't visit India 2 years, but India in my heart, all of you, my Indian friends in my heart as well. Thanks again. And because we have a very limited time frame, let's start. Really, today our talk will take Okay, our talk consists of two main parts. During the first part of our talk, we will slightly remind about main principles of deformity correction, in connection with foot deformity correction, and then we will take time for peculiarities of hexapod, orthopedic hexapod usage in midfoot and hindfoot deformity correction. Are you ready? Let's start. Really, you know better than me, then that's orthopedic hexapod. It's not a mystery device. With help of it, we can very easily to provide any kind of deformity correction. No. Orthopedic is the tool only, and we should keep in our mind main principles of foot deformity correction. We all of us know that in pediatric surgery, in childhood, we can provide close deformity correction. For adults, we have to do open surgery with help of Ilisara osteotomy and with help of foot joints fusion in combination. And of course, in 99.919%, we shouldn't avoid soft tissue procedures. So, the main idea of deformity correction is extremely simple. We should identify axis of proximal bone fragment, distal bone fragment, and provide alignment.
Sir, sorry, Professor Leonid, may I just interrupt? I think, sir, are you moving your slide? Because I cannot see the slide moving, sir. If you can.
Oh, really?
Yeah.
Okay. What should I do? Okay, let's check. That's why we agree with you to check all my presentation.
Yes, sir.
How far? Okay, you can see just now. I'll start. You can see changing of slides.
I cannot see. I think, sir, you will have to, do the slide in the play mode, sir. Play slide mode.
Yes, but what? What should I do? Because
Rishi.
Okay. I'll try start again. Yes. Okay. Can you see my title?
I can see the first slide, sir. That shows mid and hindfoot deformity analysis.
Yes. Now there is moving of slides, no?
Slide is not moving, sir. So I think
okay. What should I do?
I think, sir, if you can just try playing on the play mode, sir. On down below there is this flask kind of a structure. Right below where there is 70% written, sir. Just next to it, maybe it will start playing.
Okay, okay, I'll stop my presentation. Okay,
Yes.
what should I do? Okay, start again. Can you see it?
Yes.
No,
Now I can see your slide in full slide mode, sir. Now, can you just try and change the slide once, sir?
It's strange, my friends. It's technical problem. And now, no movement of slides.
Okay.
You can see movement.
I cannot see movement.
What should I do?
Sir, can you just hold on for 2 minutes? I will just sort it out. Just give me 1 moment, sir.
Okay.
Sir, please change the slide once again. It just moved. Yes, one slide. You come back to the slide share mode again, sir.
Okay, I can see
Yes.
the note. You started demonstration. Okay, I am okay.
Sir, even I am seeing your first slide. So
okay, but I am on the second slide. I am the first slide. I am the 10th slide.
So that slide is not moving, and I
Yes.
think you have to go when, sir, on top of your screen there is a slide play mode. Slide play mode. When you
sir. Hello, Dr. Manish, good evening.
Hi.
Yes.
Huda sir, can you please help out Professor Leonid? His slides are not moving, sir. We have a lot of things. Sir.
Sir, do we have a slide share button on the? Yeah, please go, sir. Please go full screen. It's okay. It's coming.
His slides are not changing only, sir.
Okay.
Okay, one more time.
Yes. Sir.
Yeah.
Yes, one more time. It's moved? No?
No.
No. I don't know. What can I do?
It is the first slide, sir.
Professor Solomin.
Yes.
Why don't you press F5 on your laptop?
Yes, F5. Yes.
Yeah.
Yes, F5. Yes, is it?
No, but it doesn't go to the slide.
Move the slide this way also. Is it not moving?
It's going. No, first slide only.
Moving. Or
I can't see the slide move.
Me too. Okay, I'm very sorry. We
can
check presentation
Siddharth,
Neeraj.
Yes, Rishi. Rishi?
Anybody from OrthoTV can help.
Yes, so can you make Dr. Manish the co-host and he can change the slides? I mean, if that's possible.
In that case, he has to mail the slides to him.
No. So if he makes him the co-host, then the slide control can also be given by Professor Solomin to one of the other people.
Right.
They can co-present, yes.
Yeah.
I think he has made me the co-host.
Okay, Professor Solomin, can you stop?
Yes.
Yes, can you stop screen sharing once?
Okay.
Okay, just please stop screen sharing once.
Yes.
Yes, and then go to the part where you click on share. Click on share and then select only the window with the Microsoft PowerPoint.
Yes, I have only PPT. Okay, may I share with you?
Yes.
Okay. Can you see me? I'll share it.
Yes. Now, can you
Yes.
please click on the icon which is next to the 70%?
70. Okay.
No. The icon which is just left to the percentage. Do you see the
Yes.
number 50%, 60%? Just click on the
Okay.
small icon on the left side of this.
On the left of 90%, sir.
Okay, okay,
Yes.
no. Okay. Now I have 90% of my screen. 90%. It's too much.
Dr. Neeraj Bijlani is joining. Dr. Siddharth, Neeraj Bijlani is joining. He'll be helping.
Okay, sure.
Okay. No movement.
Professor Solomon, please
Yes.
click on that little icon next to the percentage. Okay, so yes, now it's in full screen mode.
Yes. Full screen mode, yes.
Yes, please go to full screen mode. Yeah.
Yes, full screen.
And then go to the next slide now.
Yes, I'll try. That's good.
Yes, so it's moving now, yeah.
Ah, great.
Yes.
We are ready to start?
Yes, we are, yes.
Okay. Okay, let's start from begin. Okay, today our talk, I will speak speedily, consists of two parts. The main idea of the first part to remind principles of deformity correction, and second part will be devoted to peculiarities of hexapod usage in midfoot and hindfoot deformity correction. And let me repeat, it's not a mystery device, orthopedic hexapod. Hexapods, it's a tool only to provide general ideas of foot deformity correction. And you know better than me that in pediatric practice, we should prefer closed surgery. In adult, we have to use open surgery with help of osteotomies and fusion, or with their combination. And in 90.99%, we shouldn't avoid soft tissue procedures. And main idea of deformity correction extremely simple. We should identify axis of proximal bone fragment, axis of distal bone fragment, and provide alignment axis of distal bone fragment relative proximal one. And the first and second osteotomy rules. The best solution is osteotomy on the coral level. Alignment will be axis to axis, cortex to cortex. But when we have no possibility to provide osteotomy at coral level, we should do translation, the second osteotomy rule. The more distance from the coral level to osteotomy side, the more translation should be done for alignment, axis to axis, but this cortex translation. It's very simple. What's in our Bible to identify axis of proximal and distal bone fragments? Of course, reference lines and angles, anatomic, mechanical axis, and joint lines. It's very simple. For the AP, only one proximal angle and distal. Proximal and distal. Extremely simple. But let's look, foot. How many bones? Too much angles, lines. For AP, for lateral view, for hindfoot, for midfoot, for combined deformities, for axial deformities, huge number. How to identify axis of proximal and distal bone fragment to provide, to identify osteotomy line and provide deformity correction according to first or second osteotomy rule. It's very simple. It's very simple, my friends. There are special integral reference lines and angles for midfoot and for hindfoot. Let's go step by step. AP, reference, lines, and angles. The key point is Chapar joint line. Chapar joint line is unit. It can be measured in millimeters, centimeters. Absolutely doesn't matter. Absolutely doesn't matter. Length of Chapar joint line is universal unit. Simple. Let's go forward. How to identify anatomical axis of second metatarsal bones? Nothing special. Normally, the anatomical axis of the second metatarsal divides the Chapar joint line into half. Medial angles about 90 degrees in normal, not deformed foot. And the distance from Chapar joint line to anterior cortex of the second metatarsal can be calculated. AB length of Chapar joint line is unit. It can be, for example, 60 meters or 55 millimeters. Doesn't matter. How to identify proper length of midfoot? We should multiply Chapar joint line in millimeters, in centimeters, in meters to coefficient. This coefficient 2.4. How to realize this knowledge in practice? How? Let's start planning of deformity correction. Let's draw Chapar joint line. Very simple. And let's identify proper anatomical axis of second metatarsal bone. It should coincide. No. Oh, analysis. There is deformity. Let's start planning of deformity correction. Let's identify anatomical axis of the second metatarsal. Axis of the proximal bone fragment, axis of the distal bone fragment, cora, and we can provide osteotomy at coral level. Let's do it. Voila. It's alignment. Axis to axis. But what about length? For example, AB Chapar joint line, 75 millimeters. Let's multiply to coefficient 182 millimeters. We should provide distraction. My friends, that's all. Very simple. One more time. Chapar joint line, divide into half, 90 degrees angle, and this pink axis doesn't coincide with real anatomical axis of the second metatarsal. We can identify cora level, osteotomy, and provide planning of deformity correction. What about length? Oh, it should be shortened. It's planning of midfoot AP deformity. Not too difficult. What about lateral view, reference lines and angles of midfoot? Key point for lateral view, talus joint line. Talus joint lines, its unit, the same, can be measured in millimeters, centimeters, decimeters, doesn't matter. Doesn't matter. So normally, posterior point of talus joint line crosses with mechanical axis of the first metatarsal at angle about 24 degrees. Normally, in not deformed foot. And anterior cortex of the first metatarsal should be identified with help of coefficient 4.3. So how to use this knowledge, how to provide deformity analysis and planning of deformity correction. Let's identify key point. Talus joint line. At angle 24 degrees, draw the second line. All of us remember that this green line should coincide with mechanical axis of the first metatarsal. I can see it doesn't coincide. Okay, let's draw mechanical axis of the first metatarsal, and there is apex of deformity correction. To provide deformity correction according to the first osteotomy rule, we should do osteotomy at this level. That's all. Perfect alignment. What about length of midfoot? For example, for this particular case, AB talus joint line 35 millimeters. Let's multiply 35 for 4.3. And distance from posterior point on joint line to anterior cortex of the first metatarsal should be 150 millimeters. That's why, in addition to alignment, we should provide lengthening. That's all. Clinical case. There is deformity or no? Okay, I am not sure. Let's check. Talus joint line. And from the posterior point of talus joint lines, let's draw the green line at angle 24 degrees. All of us can see this green line doesn't coincide with mechanical axis for the first metatarsal. Okay. Simultaneously, let's identify the proper point C. What means point C? In not deformed foot, it should coincide with anterior cortex of the first metatarsal. There is deformity. Let's provide planning of deformity correction. Let's identify mechanical axis of the first metatarsal. Oh, what means this crossing point? It's Cora. It's Cora. Let's try to do osteotomy at Cora level. 1, 2, 3. Voila. But for after deformity correction, we can see that anterior cortex coincide with point C calculated previously. And we can use this planning for a real deformity correction. Axis to axis plus proper length of midfoot. What about hindfoot? Almost the same. Almost the same. On the basis of talus joint line coefficients, we can identify correction principles of hindfoot. And you know better than me, for axial projection, anatomical axis of calcaneo should be a little bit laterally 8-10 millimeters, and can be slight bulgization. So it's very simple to provide deformity correction planning for hindfoot. Let's draw anatomical axis of tibia, anatomical axis of calcaneus, the same for right side. Oh, there are crossing point Cora levels. Let's do simulation of deformity correction. Line are parallel and with 8-10 millimeter lateralization. It's planning of hindfoot deformity correction in action. What about lateral view? Let's discuss it more precisely, more in detail. The same key point is talus joint line. Should be measured in millimeters, centimeters, doesn't matter. So, talus joint line. We should identify crossing point of continuation talus joint line with anatomical axis of calcaneus for lateral view. How to identify this point? We should multiply length of talus joint line to coefficient 2.5, 2.6. Is coefficient 1. And in normal, not deformed foot, anatomical axis of calcaneus should be identified at angle about 15 degrees. So, talus joint line, continuation, anatomical axis of calcaneus, continuation, crossing point C. It's normal, not deformed foot. How to identify proper length of hindfoot? Very easily. The same way, with the help of length of talus joint line. We should multiply talus joint line length on coefficient 4.6. Let's start. There is deformity or not? No, let's look. Okay, step by step, step by step. Let's identify talus joint line. Let's identify point C using coefficient 2.6. For example, AB talus joint line 35 millimeters. That's why BC distance should be about 90 millimeters. Let's draw second line. In normally, this green line should coincide with axis of calcaneus. Oh, I can see it doesn't coincide. Let's identify proper, real axis of calcaneus. There is crossing point of real and proper lines. What does it mean? It means cora, apex of deformity identification. It's possible to provide osteotomy here and follow to the first osteotomy rule. Why not? Let's provide alignment, axis, green, pink axis, relative proximal fragment, green axis. But what about length of hindfoot? Let's multiply 35 millimeters length of joint line for this patient to coefficient 4.6. And normally in non-deformed foot, distance from C to D should be 160 millimeters. What does it mean for this particular case? We should do distraction. Voila, that's all. Clinical case. Let's do it together. What should we do firstly to analyze this deformity? Help me, please. I agree. We should identify talus joint line and identify point C using coefficient 1, 2.6. After that, at angle 50 degrees, we should draw the second line. Normally, this green line should coincide with axis of calcaneus. No, there is deformity. It's analysis. Let's provide deformity correction planning. Let's draw calcaneus axis and crossing point of these lines It's possible to do osteotomy here for hindfoot deformity correction. No. And the same principle, similarly to long bones deformity correction, the more distance from the coral level to osteotomy side, the more translation should be done. Absolutely the same principle. Next example, midfoot and hindfoot deformities correction. Very simple, extremely. Let's identify axis of proximal, so-called bone fragments, and distal one, core identification, and alignment with left lensing if needed. Next, calculation, planning of where is this deformity in presence with ankle fusion. For this method, we should only identify talus joint line or imagine talus joint line. That's all. For midfoot, for hindfoot, this method doesn't depend on deformity of tibia, ankle deformity, plantar flexion, dorsiflexion, doesn't matter. And for joke, of course, it doesn't depend presence of foot. 1, 2, 3. Voila, it's foot reconstruction. But not please. Coefficients. Alignment, it's simple. It's very simple alignment. But should we use coefficients in all cases? No, 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 no. We must use coefficient when we have both feet deformed. And it's very logical. Where one foot is normal, second deformed, we should compare length of normal and deformed foot and forget about coefficients. There are a lot of publications, relative reference lines and angle. Previously, I sent you this presentation. Take it, please. Enjoy. And these reference lines and angles available in very popular program, Bone Ninja. Use it, please. And now we are ready to move to the second stage of our today talk. The second reason of our today meeting, discuss about possibilities of orthopedic hexapods in midfoot and hindfoot deformity correction. First of all, let me slightly remind you, there are 3 types of hexapod platforms. Gauff-Capel platform, Stewart, and SUV. Peculiarities of Gauff-Capel platform, separate fixation of each of strut. Let's move to orthopedic language. Separate fixation of each of strut to the proximal and distal. 6 points of fixation proximally and 6 distally. Stewart platform, 3 points of fixation proximally and 2nd distally. And SUV platform, 3 plus 3 platform. There is wrong opinion that all orthopedic hexapod based on the Stewart platform. No. No one orthopedic hexapod based on Stewart platform. Most of hexapods based on Gauff-Capel platform, 6 plus 6. And orthopedic hexapod or the SUV frame is based on correspondingly SUV platform. What are peculiarities of 3 plus 3 platform or the SUV frame? Its frame. To start 6-axis deformity correction, you should have only 6 struts in your focus, no rings, no more, and software, of course. That's why really, or the SUV frame, it's not a frame, it's software-based reduction unit. Because these 6 struts can be fixed to any kind of ring. Ilizara arch, half ring, 3/4 ring, full ring, of course. any inclination of rings can be used with OrthoTV frame assembly. And bone can be located in the center of ring eccentrically, doesn't matter. Any holes can be used for struts fixation, absolutely any, in any length of struts. It's not limited, because length finally depends on threaded rods. Yet these threaded rods can be 1 meter, 2 meters, adapted with telescopic rods, doesn't matter. And the unique capability of OrthoTV, with this free frame assembly, we shouldn't add additional data in the software. OrthoTV frame quite popular, I hope, in India, and like another hexapods, there is some disadvantages. For pediatric practice, it's a little bit bulky. It's possible to provide deformity correction very accurately, precisely, but a little bit bulky. What should we do? We should, in this particular case, use minimized version of OrthoTV. Minimized OrthoTV. Compare standard SUV and minimized one for femur deformity correction with this girl, and for forearm deformity correction in pediatric practice. And in the near future, we will discuss possibilities of minimized OrthoTV with hindfoot and midfoot deformities correction. And of course, unique possibilities of OrthoTV software. Conventional terminology: minimum number parameters should be input, full visualization, yellow bone contour, initial position of bone fragment, mobile bone fragment, and red bone contour calculated by software, final position after deformity correction. And absolutely unique possibility of OrthoTV software, multi-total residual. What's mean? It's a picture, of course, for joke. Our main idea of hexapods to provide deformity correction on shortest way from point A to point B. From time to time, where we have overlapping bone fragment, and a lot of there are a lot of situations where we shouldn't use shortest way of deformity correction. First step, second step, and compression. And multi-total residual option of OrthoTV software can provide any trajectory of distal bone fragment before distal bone fragment will move to proper position. For joke, we can write your name, Leo, and after that provide line. It's joke, of course, but it's very useful option. What about hindfoot in connection with these OrthoTV peculiarities of hardware and software? We shouldn't use special foot rings. Special foot rings should be used in other kind of hexapods based of Gauss couple 6+6 platform. Regular Elizarov rings. Note please, we can provide stabilization of ankle joint, but it's not peculiarity of hexapod. It's main rule of external fixation in connection with foot deformity correction. Similar for Elizarov hexapod, Elizarov hinges for midfoot and hindfoot deformity correction. But for standard conventional OrthoTV, we should use dummy ring, because length of standard hexapod OrthoTV couldn't be inserted when distance between rings too short. That's why we have to use dammering. Quite conventional hindfoot module. It can be based on bias, half pins, their combination, and so on. It really doesn't matter. And for different cases, we use different options of hindfoot deformity. The main idea to provide stable fixation of hindfoot. Like similarly, it's shown on this picture. Couple wires and half pin. And again, it's possible to use conventional OrthoTV. I'll show you a little bit later with very accurate deformity correction, but a little bit more bulky because we have to use dammering. Minimize OrthoTV is minimized OrthoTV. We shouldn't use dammering, and it provides possibility to do frame less bulky. And of course, don't forget for stabilization of ankle. We are ready to move to software. Software is working on the basis of reference lines and angles we discussed above. Talus joint line, continuation, point C, 15 degrees. And that's why we kindly recommend you before to insert X-ray into software, draw this planning of deformity correction. And after that, insert this prepared X-ray into software. Okay, let's imagine, to simplify our talk, it's a picture of model, but let's imagine it's a patient picture, and this marked axis of proximal bone fragment, green line, this X-ray being inputted into software. And with help of special tools of OrthoTV software, pink tree, green tree, pink tree, it's axis of distal bone fragment. Let's provide very accurate axis of hindfoot, real axis. Green axis, it's normal axis, and its axis of proximal bone fragment, and pink tree, pink line, it's a real axis of hindfoot in lateral view. And yellow point to provide, according previously realized planning of deformity correction, proper length of hindfoot on the basis of coefficient 2. It's very simple to identify axis of proximal bone fragment, green line, it's anatomical axis of tibia, and anatomical axis of calcaneus in axial view. How to explain software position of distal bone fragment? Let's do while left clicking mouse yellow bone contour. I remember yellow bone contour is initial position of calcaneus before correction. Red bone contour is calculated by software position of mobile bone contour, doesn't matter, femur, upper arm, forearm, lower leg, calcaneus. Red bone contour means calculated by software position of mobile bone fragment after deformity correction. And in connection with hindfoot in axial view, let's provide translation, lateral translation of distal bone fragment. Structure risk. What does it mean? Like in all orthopedic hexapod programs, we should provide software with data. On the basis with them, software calculate proper days needed for vary this deformity correction. Really, that's all. 5, 10, maximum 10 minutes. Calculation with OrthoTV software. Yellow bone contour, red bone contour. And let's start according to Lizarov principle, main principles of osteotomy deformity correction. Deformity should be started in 3 days. Using hexapod, using Lizarov hinges, absolutely doesn't matter. After deformity correction, on the basis of general rules of foot deformity correction, we can make changing transition to internal fixation. Is much better, more comfortable patient. But if there are contraindications for internal fixation, we should change bulky struts to Lizarov hinges and continue fixation period. Very simple example. Post-traumatic hindfoot deformities, planning of deformity correction. Remember how to do it with help of talus joint line, coefficient 1, coefficient 2. Applying of standard hexapod, you can see, of course, any kind of deformities, including pediatric deformities, hindfoot, midfoot, can be corrected with conventional ortho SUV. Yellow bone contour, red bone contour, perfect alignment, and transition for internal fixation. We are ready to move to the final part of our meeting, midfoot deformity correction. Proximal module with fixation of ankle joint. Distal module with fixation of midfoot. And don't forget to stabilize all bones and joints distally from osteotomy. Really, it doesn't matter, you know, of course. It doesn't matter if Lizarov frame is used, or hexapod, talus special frame, or SUV, true luck. Absolutely doesn't matter. After that, osteotomy and applying of struts. Look, note please, we shouldn't use special, let me repeat, special foot rings for very this orthopedic hexapod. All frame is assembled on the basis of conventional Lizarov or similar set. But if we use standard conventional ortho SUV, we have to use Z plate to increase distance between proximal and distal modules. Frame is ready. Conventional Lizarov rings, conventional, really conventional Lizarov frame assembly, but instead of Lizarov hinges, hexapod. When we use minimized struts, frame became less bulky. Enjoy. We are ready for software. It's similar, not too difficult. I remember the anatomical axis of the second metatarsal should divide chapar joint line into half at angle 90 degrees. That's all, normal. And mechanical axis of the first metatarsal should cross talus joint line at angle 24 degrees. That's all. And when there are both foot deformities, we should use coefficient to identify proper length of midfoot. prepare X-ray with identification green line its axis of proximal bone fragment, proper axis of midfoot. It's very simple to identify with help of special OrthoTV software tools, so-called green tree and pink tree axis of proximal bone fragment. Talus joint line should be divided into half, and crossing point in the middle of talus joint line at angle 90 degrees. Check it, please. Pink tree. Identification of real anatomical axis of the second metatarsal. It's very easy to do with help of pink tree. Lateral view, yellow bone contour. What does it mean? Yellow bone contour is initial position of mobile bone fragment. Voila, that's all. We explained software axis of proximal, distal bone fragment. We explained software peculiarities of frame assembly, length of struts, length of three angles, projection of strut. And software calculate us the proper position of midfoot. Let's look at red bone contour. We should provide where is this deformity. And of course, don't forget to provide software with data. On the basis of it, software will calculate proper days needed for deformity correction, for where is this deformity correction. It's extremely important. After that, let's click button, preview, and software will give you prescription. How many should be changed length of each of struts during all fixation correction period. And the same, similarly to hindfoot, after deformity correction, it would be better to provide transition to internal fixation, or if we have a contraindication for internal fixation, we have to use constant fixation with frame for all fixation period, frame only. A couple clinical cases. Oh, I enjoyed this case. I enjoyed this patient. Looks post-traumatic deformity and a much better picture. Enjoy. Ooh. What should we do? Maybe it would be easier to understand what should we, how can we start deformity correction with help of CT? Oh, much easier. What should we do? What should we do? By the way, several times amputation was offered to this patient. Let's start deformity correction. Okay, applying of frame, your conventional OrthoTV, not minimized, and we started with hindfoot deformity correction to improve like first step. Third time, I know first step because it's not too easy for us was to provide proper alignment. Yellow bone contour, red bone contour, really real position of hindfoot coincide with calculator of software, and we moved strut from hindfoot to midfoot and provided hindfoot deformity correction planning, yellow bone contour, red bone contour after deformity correction, and fixation period. Let's look. Something wrong? It's better. Okay, it's better, but inclination, torsion of hindfoot 60 degrees. We understood it from the beginning of treatment of this patient. But without without triple fusion to have the basis. We had no possibility to provide this big angulation of distal bone fragment. But after there is solid bone after triple fusion, we had possibilities to do it. Again, applying OrthoTV, standard OrthoTV with dummy ring. Again, calculation, angulation, translation, and rotation. Look, picture. Before deformity correction and after deformity correction. Before and after. It's provided result of deformity correction at the end of correction period. Perfect alignment for lateral and for axial view. And we were happy to provide transition from external fixation to internal. By the way, patient was happy too. Look, just after couple 5 days after transition to internal fixation, in 2 years, 2 years follow-up, and compare before treatment, after treatment, before and after. Final case, complex deformity, midfoot, hindfoot deformity, planning, conventional planning, and V osteotomy, conventional V osteotomy for midfoot and hindfoot deformity. And we started this hexapod to correct deformity of hindfoot, and this Elizarov hinge deformity of midfoot. It's point for discussion. Initially, we tried to apply couple hexapod for midfoot and hindfoot, but it's not too easy. 6 struts, 6 metal strut rings. We couldn't see the bone. That's why the last 3 years we prepare combination. Firstly, we provide hindfoot perfect alignment with hexapod. At the same time, while we perform alignment of hindfoot, hexapod-based alignment, we do approximately destruction and possible correction with help of Elizarov hinges. Software calculation and hardware provided very accurate correction, millimeter to millimeter, angle to angle, according to software calculated. And after that, we moved 6 strut from hindfoot to midfoot. Initially, we, let me repeat, provided approximate deformity correction with Elizarov hinges and perfect alignment with help of hexapod. It's much easier. Time for deformity correction period shouldn't be more longer, the same. It's picture at the end of midfoot and hindfoot deformity correction. After frame removal. Compare complex deformity before and after correction. So, my dear colleagues, my dear Indian friends, of course, it's very simple to understand that reference lines and angles, it's our Bible, it's our basis for long bone deformity correction and for foot deformity correction as well. Similar to the long bone deformities, these simple deformities, only angulation, one company. It should be more convenient to use Elizarov hinges. For complex deformities correction, long bones, hindfoot, midfoot, it would be better to use ASAMIC hexapod to provide very accurate alignment and enjoy these unique possibilities of hexapod based on 3+3 platform. Of course, it's not the education lecture and it's only show. And I kindly invite you to our institution in St. Petersburg, 850 bed, one of the 22 departments. It's our deformity correction department, trauma and consequences of trauma. And we are ready to provide you 4 levels of XFIX and limb lengthening and the reconstruction education, from the basic Elizarov course to the 4th course, combined and consecutive use of external and internal fixation. And of course, regularly we provide basic and advanced ortho SUV course. Basic course, long bone deformities, advanced and master course, foot deformity correction, ankle and knee. Thank you. Are you not sleeping, my friend? Are you not sleeping?
No, we are not sleeping. Thanks for the unit, Solomin. Actually, you have taken the deformity correction just to the next level. The way you have presented your slides and the way the deformity correction planning in basically foot and ankle, especially the foot deformity, it's really an excellent presentation. Thanks a lot.
Thank you. Thank you. It's especially for you.
Are there any questions, Dr. Siddharth?
Yes. So, Dr. Solomin, excellent presentation. You are a master of deformity correction.
Thank you. You master too.
Yes. So my question to you is, if you are doing a gradual correction of equinovarus deformities, because these are the commonest deformities we see in India, do you do a tarsal tunnel decompression routinely when you are doing a gradual correction for equinovarus deformity of the foot?
Okay, it's a very interesting question because it is typical mistake. Equinus deformity. What's mean equinus deformity? Equinus can be equinus in ankle joint, equinus. It can be deformity of distal tibia, equinus, and it can be midfoot equinus, and it can be hindfoot equinus. 4 components of equinus. That's why we should correct each component of equinus separately. It's very simple. If there is flexion deformity of distal tibia, osteotomy correction. If there is equinus of ankle, correction. And if there is equinus of midfoot, correction. We shouldn't combine these separate points of equinus deformity. And each of these points has peculiarities of correction. Distal tibia, gradual deformity correction or acute deformity correction. Ankle deformity correction, this help of Elizarov hinges or this help of multi-total residual, and we shouldn't provide rate 1 millimeter per day. It depends on rigidity of soft tissue only. And midfoot equinus should be corrected correspondingly. We've discussed above. Very simple.
Yes, thank you, Professor Solomin. So for the sake of discussion, let's say it is an ankle equinus deformity. So if you were doing a gradual correction of ankle equinus, would you decompress the tarsal tunnel at the same time?
First of all, of course, we should provide a lengthening of Achilles tendon. It should be close technique and a posterior release of ankle joint. And in most situations, we can not constantly remove equinus deformity, but about 40%. And of course, release to avoid neurological problem. I completely agree with you.
Thank you, sir. Thank you.
Thank you. Thank you.
Dr. Solomin, in your deformity planning, you have taken the 2 reference points on the talus.
Yes.
Yeah. So what if we are not having those 2 reference points, if the talus is malformed or like that, or our deformity planning is based on the prerequisite that our talus is okay?
Really. We can, okay, it's when we have deformed talus, we can imagine distal tibia, it's talus, it's deformed talus. Let's imagine it, proper position. It's not too difficult. Okay, draw this line, midfoot, hindfoot. Okay, but you see, because we should provide ankle fusion because talus deformity, we should this construction provide any angulation, but form of hindfoot and midfoot will be the same, and we will move to provide angulation relative tibia. That's all. It's not too difficult. Imagine if you have no talus.
Thank you. Dr. Manish, are you having any question?
Sir, just a basic question. Firstly, an excellent presentation. I had introduced
Thank you,
Dr. Solomin, so I said that we are expecting a blockbuster presentation, and it was like that. Just wanted to know, you demonstrated some very nice techniques of bony, the osteotomies, and most of them are cancellous bones. So what is the fixator removal time? Is it a little early, or what in general you have noticed, sir? The removal time of the fixator, how do you judge it?
Oh, already it's main principle. There are not special tips and tricks connected with hexapod. Hexapod really make time of frame shorter because all components of deformity can be corrected simultaneously, not like in Lizara frame. And after that, of course, let me repeat one more time. In 100%, when we have possibility to change external fixation to internal one, we do it for plate, for nail. It's conventional way. It's unfortunately not we offered it. Transition for external to internal fixation. We do it every time.
Thank you, sir.
Thank you, sir. So I think we should wrap up it now. We had an excellent presentation, Dr. Leonid. And next time, definitely, we will be, if we are having more than 2 hours or like that, then we can plan for the virtual workshop along with the delegates and planning on the paper, as you said that you had a plan for that. So definitely in coming future, we will plan for that. And thanks a lot for coming today. And it was an excellent presentation indeed.
Thank you. Hope next our president will do face-to-face. Online it's good, but
yeah, definitely. We will plan it accordingly. We will plan it accordingly, though it will be virtual, but we will plan it accordingly, like it should be interactive.
I understand. It
should be interactive.
Not so easy, but my desire to join us and having the glass of beer after our lesson to continue our discussion.
We will plan accordingly. Definitely.
Okay. Thank you. Bye. Bye.
Thank you so much for sparing your time.
Thank you. Thank you, my friend. Thank you. Bye.
Thank you, sir.
Good night, everyone.
Thank you.
Thank you, sir.
Good night.
Samshul, are you there? Neeraj, sir?